Unfettered access to reproductive and gender affirming care is a basic human right. Keep listening to hear about threats to this access and how to preserve it.
Hello, pharmacists and friends. Today is Wednesday, March 20th, 2024, and welcome to the Regimen, where public health pharmacists, pharmacy students, and our guests discuss the latest public health issues. Listen in to find out how we can all improve population health, health equity, and patient care through advocacy and education. My name is Tony Sulo. I'm a sixth and final year Doctor of Pharmacy student at the University of Rhode Island, working alongside Dr. Bratberg and the Rhode Island Department of Health.
And I'm Jeff Bratberg. I'm a clinical professor of pharmacy practice and clinical research at the URI College of Pharmacy and the Academic Collaborations Officer at the Rhode Island Department of Health. As a reminder to our listeners, the opinions expressed in this podcast by the hosts and guests do not represent the opinions of the United States government, the Rhode Island Department of Health, the University of Rhode Island, or Duquesne University.
Today, we'll be discussing reproductive and gender-affirming healthcare. We are honored to be joined by Jordan Covvey, PharmD, PhD, BCPS. As an associate professor, she has didactic teaching responsibilities in the PharmD program and across campus in interdisciplinary courses primarily centered in healthcare structure, public health, global health, and literature evaluation. She serves as a preceptor for research-oriented API PharmD students and for academia research rotations for pharmacy residents. As a social administrative scientist, her research focuses on quality improvement in medication prescribing, utilization, and associated health outcomes. Her work extends across several clinical areas, including internal and emergency medicine, mental illness, substance use, infectious disease, oncology, obesity, and pain management. Jordan, thanks for being here today.
Thanks so much for having me. It's a really great pleasure to come on here and have a chat about this really important topic today.
Yeah, I wanted to start out today by talking mainly about access to reproductive health care. It's kind of a hot topic going around now. And so I wanted to discuss your editorial, Actions Speak Louder Than Words, taking a stand for reproductive health care and gender affirming care. So in your editorial, you discussed the 2022 Supreme Court case, Dobbs versus Jackson Women's Health Organization. What were the implications of Dobbs versus Jackson on reproductive health care?
Yeah, it's a really large and changing landscape over the last couple years. And, as Jeff and I were preparing this editorial, this was part of a special issue or a special themed issue with Journal American Pharmacists Association. And we based this editorial looking at changes in this landscape. And to bring it down to its simplest terms, the Dobbs versus Jackson decision essentially removed federal or national level constitutional protections for abortion that had almost 50 years of precedent in the United States. So it was a really kind of huge change in this landscape, because what it ultimately has resulted in over the last couple of years is a state level patchwork of access to reproductive health care. I kind of think about it similarly in the vein of how we have Medicaid access in the United States, right? Depending on where you live, one of the things I talk to with my students all the time is that really has a huge influence on the type of healthcare you have access to, right? If you're in a state that has expanded Medicaid programs with the Affordable Care Act back in 2010, you're more likely to be able to access Medicaid in your state, and therefore, access a whole host of positive outcomes that come with having access to health insurance and the ability to gain entry to the healthcare system. But what we're seeing here after Dobbs v. Jackson is the exact same thing is happening with reproductive health care, and specifically access to abortion, where now we have certain states where individuals cannot have access to the full list of comprehensive reproductive health care services, whereas in other states, things have largely remained unchanged since that decision in 2022.
And I think the interesting thing here is that it's affected pharmacists. So Jordan and I are editors of Jaffa. We should probably disclose that, and
Yeah.
associate editors. And so hence that editorial. We started talking at the AACP conference right after Dobbs passed about we should do something, and then the theme issue came and it just all fit. But I think the interesting thing in researching this is it affected pharmacy. That's why it's in a pharmacy journal, not just the people themselves who are affected, if they're people who wish for or are accessing gender affirming care or pregnancy services or pregnancy loss services, but it's really affecting them in terms of all the other things that in state policy. Tony and I were at the Rhode Island State House last night, testifying for bills because we have to pass them state by state. Here, even though states had limited abortion in various ways, but without sort of breaking that high bar that Roe v. Wade had, now they're doing all sorts of things. But the most interesting thing, I want to hear what you think about this, is that since that ruling, the goal of which is to reduce abortions, at least in the states that overruled it, is that there are actually nationally more abortions done post Dobbs than before, and more than a trend in increasing abortions or increasing medication abortions. So what do you think about that? If the goal was to reduce abortions and we actually saw more, what do you think about that?
And I think there was just data released this week on that particular issue that was looking at trends longitudinally, confirming exactly what you just said. And to me, it gives a lot of echoes with the impacts that we've seen on whether states have sex education in public schools that focus purely on abstinence versus kind of the comprehensive programmatic sort of goals that we would hope that they would, right? Looking at data from that perspective, we always see that states that focus on abstinence only education have higher rates of teen pregnancy, as an example. So I think what we're seeing is a very similar trend with the implications of Dobbs here, because one of the sayings that we go through and that many people fear with restrictions on abortion is it doesn't necessarily change whether people pursue an abortion. It perhaps just makes it less safe. And in this case, it perhaps is shifting where they are seeking abortions. So I think in that data that you're referring to, looking at some of the geographical trends, there has been major increases in states that geographically border states that have, severe restrictions. And, being here in Western Pennsylvania, we are kind of in one of those areas potentially where restrictions kind of surround us in many different ways. A number of states have fallen into that, and I think that's important to consider because number one, those are people who are able to travel. We know that many people cannot and perhaps don't have that ability to do so. But also for individuals who live in those states where access to abortion still remains, the capacity of clinics to be able to service needs for a whole host of patients with very time-sensitive healthcare needs is really kind of difficult, right? So one of the things I think is really important when we talk about access to reproductive healthcare services, and I think if we talk about access to gender-affirming care and so many other healthcare issues, I think, from a human nature perspective, sometimes it's easy to say, well, oh man, I'm glad that that's not happening in my state. These states need to fix their own problems, but we're all in this together. This is something that impacts all of us as a community of people. And, it makes it even more important that we say that all people deserve access to a whole host of healthcare services, and that those decisions can happen between a patient and their healthcare professional at the time that is needed without significant barriers to that access.
And I think Tony's got another great follow-on question to that, but I think this is all about representation, right? We have more than 50% women in this country, or people who can get pregnant, and our legislators do not reflect that, nor does the Supreme Court. So I think when we think about that, it just really, it's one thing to say like, oh, last night we were talking to the pharmacist member of our legislature. There's one, right? Is there 50% women? Close, but it's not there, right? But they have influenced actually putting Roe v. Wade into law in 2019 after an influx of women came into our state house. And we were talking about that yesterday or this week. So I think that's really interesting. And then on the travel thing, I think what's interesting is states are pretty savvy to watch these trends. And, there are counties in Texas that are trying to say you're fined if you're traveling through our county to go to another state. I mean, it's really interesting, and we have to be aware of these kinds of access issues.
Well, you bring up a really good point when you were talking about our initial discussions, in the aftermath of this decision when we were talking at AACP. And I remember that conversation when we were discussing, there's the implications on us as a profession from a healthcare perspective and kind of that larger structural level. But what I remember us also discussing is the fact that, as a profession, pharmacy is, majority women. If we look at the demographics of who's coming through school today, so this is like this really important intersection between professional and personal identity and how these laws impact people and their ability to, the ability of every pharmacist today to both do their job in a professional setting, but also to live their life personally and to be able to make decisions based on that. And I would even take that a step further to say, like talking about this issue, it's natural for us to focus and say, this should matter because we have a lot of women and there needs to be representation, but this should be just as an important issue to people of all genders, right? The topic of family planning and the ability to decide when and how you have children, if you choose to do so, is something that impacts everybody, right? And so I look at it as something that is a really great opportunity, perhaps, for allyship here, particularly not separating this out as like a women's health issue specifically, but something that impacts patient care more broadly.
I'm going to go on a tangent just because it's so fresh in my mind. So there are all these healthcare bills at this Health and Human Services hearing, and as you were talking about bodily autonomy and things, some of the advocacy groups were talking about a bill in Rhode Island that mandates insurance coverage of IVF, but only for women. And so there was an advocacy, an LGBTQ plus advocacy group saying we have to change this. Like the National Infertility Association changed their language in October. We need to sync this law so that more people get access to care. So it's just interesting when you think about the laws that sometimes it's a game of whack-a-mole where you squeeze one thing and another thing, or squeezing the balloon, there'll be restrictions on other things. And I think it's so important to say, yeah, I'm this, married guy with 2 kids. Why do I care about access to abortion? But it affects my community, it affects my colleagues, it affects that. And I think one more thing about affecting our profession is, and maybe we'll get into this later, but the idea that we have privilege, we have economic privilege as pharmacists. If we're to provide care to the best of our ability as the law allows, there are people that, at least in physicians, that are leaving these states that have these restrictions. And so I'm actually more worried about pharmacist access in those states where people like, see ya, I'm not going to train here, I'm not going to live here, I don't want to provide care. And so that also has a downstream effect on the full thoughts of the full access to all of healthcare. I don't know, what are your thoughts about people moving out of these states and the resulting environment?
There's been a number of articles that have discussed in particular how we're seeing this. And if I'm thinking, the stories that I'm remembering in particular were in places like Idaho and in Texas, where we're having what we now call maternity deserts, right? And that's not necessarily specific to the Dobbs decision, but it's in this entire area of changes, right? Where we have hospitals that have decided that having maternity wards and having OBGYNs is not financially advantageous to them. And as a result, they have closed down these particular parts of hospitals, leaving individuals who are trying to give birth or seek services for reproductive health care, potentially living in an area where they have to drive hundreds of miles in order to access that care. And, in the instance of actively being in labor and wanting to seek a hospital to deliver your baby, that's an incredibly scary prospect, right? But contributing to that, to your point, I think we have to recognize that living in a state that has written legal language that is very, very unclear, that puts healthcare professionals at risk for providing evidence-based medicine to their patients. I 100% recognize why a healthcare professional would perhaps choose to not work in that type of legal risky environment, despite their dedication to their patients, despite their dedication just to, to the patients they're serving in general. But these are the knock-on effects that we don't necessarily think about. So, like to your point, Dobbs not only impacts people who are perhaps seeking abortion-related services, right? It impacts any individual who is trying to have a baby, not have a baby, decide on what type of, birth control might be right for them or not right for them. It impacts a whole host of people beyond perhaps this one group of individuals that have been targeted for, arguably political reasons. So those are the parts that worry me more broadly. And I think as we're a couple years now past this decision, I think we've seen more of this be, come out in the news. And perhaps, I hope it gives people a little bit of perspective on how this might impact them, even if they don't think the original ruling was something relevant to their personal life.
And we actually just saw this happen in real time within the last few weeks in Alabama with the Alabama Supreme Court case that ruled that embryos would apply to the Wrongful Death of a Minor Act. And then subsequently, there were so many reports coming out that all these IVF clinics were now closing because they didn't feel that there was any like legal protections for them. And I believe it was March 7th, there was another news report within a month of the initial ruling that the Alabama governor signed that there would be protections provided for providers against any lawsuits or criminal prosecution for damage and death through an embryo because of what happened, where three of the major Alabama IVF clinics were closing or pausing service, I should say. It's kind of crazy the impacts that just one piece of legislation can have on so many different people.
One of the points I think Jeff and I try to deliver in this editorial is, and I think we deliver this hopefully from a perspective that I think can be unifying. We recognize that, from there are many different perspectives politically in particular on this issue, but I think one of the points that we try to make is that we have to be very careful when non-healthcare professionals are making healthcare decisions, particularly through policy and law. You two were talking about spending time with your legislature, and in ways this can work really well, right? When healthcare professionals are, deeply part of these processes to create policy and enact them at their state or national levels, this can be really great, right? You want to consult the experts on how to potentially write a policy. I think unfortunately what we've seen in this area, there has not been that recognition given to the healthcare professionals, the immense body of evidence-based medicine in this area, and as a result, we have ended up with language that does not coalesce with how practice happens today, and that has made the jobs of healthcare professionals so difficult. On top of the fact that, of course, we're still, still kind of in dealing with the ramifications of this pandemic, with healthcare worker burnout, with so many issues that are already piled on top of healthcare workers. Now, adding this to it, it makes it even more difficult. And I think that's the part we try to make in this editorial is that really, if we want to put forward policy relevant to healthcare, the stakeholders, in particular, the patients and the healthcare professionals, have to be the ones leading that charge and have to be the ones that are listened to some extent in the writing of these policies.
And that's what's interesting about testifying too, is that these 4 hours, which is unusual. Please, everyone, please, you can write testimony. It's fine. It's easy. You can do it. But the whole idea is that there were personal stories, right? There was a bill about specialty pharmacy medication access, and there's a person talking about her child being admitted to the hospital because the med wasn't delivered from the pharmacy benefit manager. And right next to her is the pharmacy benefit manager guy getting pilloried by the committee to be like, you just heard this personal story. What do you think about it? And I think and again, in some of these state legislatures too, there have been sort of some tempering of the laws and making sure, but we still have a dozen states that there's no exception for rape or incest. And then there's these vague laws about exceptions to the mother's health where at the State of the Union is the mother who child was going to die, applied to have an abortion based on the Texas law and got denied, and she had to leave the state to do this life-saving care, which she didn't want and didn't expect. And I bring that up because stories are powerful, and we need to hear these stories to say, kind of what we wrote in the article. What we think of as the people receiving this care is probably a broader set of people than we normally think about.
It's really important too when you think about that after the Dobbs decision was made, a number of state laws changed based on trigger bans, right? Things that were basically waiting on the books to say, well, if this actually ever changes, we immediately, are going to ensure that, perhaps abortion is not legal in our state. And it's really important to think about that because when those laws were put in place, those trigger bans were put in place, does that match the will of the people today? Have the people who are alive and like of reproductive age, the people that perhaps are the stakeholders in this particular policy decision, Do they share the sentiments at the same time that these trigger bans were put into place? And it's a really kind of important question about, how the government is effectively representing the will of the people, as opposed to kind of conceptually falling along the lines of, a particular party or something in that regard. So it's important, to recognize, like, a lot of things have changed in, the advent of reproductive health care or gender affirming care over time. We want to see evolution of things, in healthcare and in, in society. So yeah, we have to really not forget the stakeholders in all of this and make sure that they're part of this, every part of the process.
Something that I've learned over the last few weeks on this public health rotation and being a part of the legislative, I guess, side of things is exactly what you said, Jordan, the idea of like representation and just kind of showing up and letting the legislators like hearing our voices, but also making sure that they're kind of part of the other side and they are the ones who are writing these bills and sponsoring these bills. So we've talked a lot about how that kind of avenue of representation and getting your voices heard can help solve the problem. But I think there's probably other strategies that we as pharmacists can implement as well. So in your experience, what are some strategies that you've used to help connect your patients to care or help kind of expand their access to some of these harder things for them to get?
So, I originally trained as a pharmacist, but I'm a full-time researcher and academic these days. So really where I try to focus my investment in this area is through teaching. So, as somebody who's not in direct patient care anymore, what I have influence and impact on are up and coming healthcare professionals, right, as pharmacists. So, I'm one of our instructors in our public health content. And, one of the things that we talk about in particular as a very broad concept, not even specific to reproductive health care or gender affirming care, is the concept of putting yourself in patients' shoes, right? And it ties to these concepts of autonomy. It ties to the concept of empathy and understanding situations that perhaps you don't personally understand or have experienced in your life. And recognizing your role as a healthcare professional in order to do the most good in those situations, right? And I think in these particular issues in general, what healthcare professionals want is to be able to offer to a patient the whole host of services available to them in both reproductive health care and in both gender affirming care. Individuals in these particular areas of healthcare experience significant amounts of stigma, for accessing very basic things. You think about it, for patients who are perhaps trying to treat hypertension or diabetes, they don't have to go through these types of hurdles or perhaps have their, diagnoses discussed as a part of public discourse in a way that makes them feel shameful, right? So, we talk about this in public health as a way to say, like, it might not be something that you personally would choose if you were faced with this situation or diagnosis. But what can you do for that patient in front of you in order to help them reach the goal that they are looking for? And, I know that's a really broad concept, but I think it's a really good viewpoint to have on the entire spectrum of how pharmacists and how any healthcare professional should approach a patient, right? We are there to provide information and to provide the latest evidence on what is likely to help a patient. But we are also there to provide them the support and, the comfort of being in a situation where we can be somebody that they trust and that they can connect with. So I really focus on that broadly, and I think it connects to this particular issue here. And from a policy perspective, of course, in public health, we also talk about all the implications of what we've been discussing here. And there are so many policy implications in public health related to, harm reduction. We've obviously seen them quite importantly with the COVID-19 vaccines, and now a lot of backlash that we're having regarding other vaccines and an impending, outbreak of measles here in the United States currently. So there are lots of waves of these things that happen in public health, but I think returning to that very basic understanding of what our role is as a pharmacist and how we can help patients navigate their own health is really important. And so I try to focus on that in my teaching.
Yeah, that's fabulous. That the thing that's running through my mind as you're talking is it's all about people with lived experience. You know, the moment a student or a colleague says, "I had a miscarriage," or "My friend had an abortion," or even I say that, I think you get people's attention to say, You have some direct link to this, right?" One of the things that we've talked about increasing access is we have a vending machine for we call it the health and wellness vending machine on campus, and we have emergency contraception in it. And clearly there's a need. It's being purchased. I don't know who's purchasing it, but it's being purchased at times when they don't have access to health services. It's $6 a box. There's lots of other things. It's in a private area in a 24-hour room on in the center of campus. So it's interesting. I kind of want your opinion of. I really like sort of the ability that people can now buy birth control anonymously online. They can go to, get this O pill online. They can do telehealth to get access to mifepristone, literally cross their state border and, have it called in, have it mailed to their house. In about 6 days from now, Supreme Court's going to discuss whether they think that should still exist. So that's a fascinating development. What's the impact of increasing that access or that anonymous access through telehealth or mail order and vending machines, anonymous vending machines, versus really attempting to decrease the stigma of buying these products, right? Like, what are your thoughts on the balance there?
It's a really delicate balance to strike, right? Because we want to, on one hand, increase access, but for me, we're also not wanting to remove support, right? So many medications and things, if we have centered them in pharmacies in particular, whether it's been in an OTC shelf or whether it's been behind the counter, whether prescription or just behind the counter in other ways, one of the things that provides, of course, is this face-to-face time with pharmacists. For years, we have prided our profession on being the most accessible healthcare professional to the public. And as a result, I'm sure all of us across our clinical interactions have had situations where just that person being in front of you and perhaps the way the conversation went in a certain way, you were able to discover something that led to you perhaps making a recommendation that you otherwise would not have. And sometimes that can be really impactful for a patient. Hey, like, have you checked out that particular, like spot on your skin? It might need to be looked at by a dermatologist, right? That's not a service that you're going to be able to access via a vending machine, right? But on the same hand, I also recognize that not every healthcare professional provides that experience to patients. We have to listen to patients when they say, hey, the way that you're describing the profession here is great, but I don't have that level of trust with my pharmacist. I'm worried that this individual might report me to the police for something, adjacent to one of these laws. I felt interrogated by prescriptions. I've faced stigma when trying to fill this prescription, being told you need to go to another pharmacy across town. So we also have those situations, right? Recognizing that patients don't always have the most positive experience at a pharmacy counter or with a pharmacist. So when I look at, the mechanisms that you're talking about, I think there's space for all of these things, right? I'm always a person that talks about being in the area of gray, right? Swinging too far on either side of the pendulum is dangerous, right? By making everything, requiring pharmacist permission or being the person to do something for them, we limit access. By, getting rid of the role of the pharmacist and putting everything into, a vending machine, we're really kind of removing this amazing sort of impact that our profession can have. So, the middle part I think is really good. I love the idea of, like you said, the breaking down barriers and stigma. To your point, like the more that people see and interact with different things in their life, they become less scary to us, right? Many of the internal biases that we have or the things that we attach stigma to are because we don't necessarily know people who have those characteristics, or we don't necessarily have much interaction in those areas. However, when people gain those types of experiences, when they meet people or have loved ones that go through things, suddenly stigma dissipates, right? Because it's not a scary foreign concept to us anymore. It's something that's very close to home. So, like, the public availability of these sorts of things, the conversations that can be had, I think it really does go a far way in the potential to break down stigma in these areas. So I'm all for it in that regard.
One of the things that you brought up was this idea of like trust within a healthcare provider. And a lot of this is through positive interactions. We build trust through positive interactions with our patients and vice versa. I think one group of people who face stigma often are those seeking gender affirming healthcare, and the fact that gender affirming healthcare is actually not as universal as we wish it was. You did bring it up before as well, Jordan. So, just for our listeners out there, can you explain what gender affirming care means?
Yeah, and it's another kind of important issue that connects, I think, very closely to this conversation of reproductive health care. So, like, formally from the World Health Organization, gender affirming care basically refers to a really wide range of social, psychological, behavioral, and medical interventions that are really there to support and affirm an individual's gender identity, particularly when it conflicts with the gender that they were assigned at birth. So really, in the idea of healthcare specifically, we're often thinking about healthcare specifically assisting trans folks and non-binary folks. But like ultimately, you could think about gender affirming care in like a much broader concept, right? In many ways, throughout society and healthcare right now, we have a number of things that are there to serve gender affirmation for cis individuals already, right? The things that I think about are perhaps like cosmetic surgery that exists right now, or medications to, perhaps lessen hair loss, or medications to promote, medications to promote hair removal, and people trying to get rid of body hair. Thinking about clothing and beauty products. Like there's a lot of things that I don't know that we think about that deeply that are already throughout society that are focused on gender affirming care primarily for cis individuals. The concept of gender affirming care specifically to healthcare, to me, informally, is really about being able to deliver that same standard to individuals who are trans or non-binary. And of course, specifically focusing on a number of medical interventions like hormonal therapy, or, kind of other services in that arena.
Yeah, I really like that juxtaposition about we already provide, everybody doesn't like the different, but I think we can really come to the same conclusion if we go, and we wrote this in the editorial, is that these are universal things for us and for people we know. We know these folks, maybe because of stigma we don't know, or because they don't have access to care we don't know. But I really like that comparison of we already provide this for cis folks, but let's provide it for all folks.
I mean, gender affirming care really has the opportunity to benefit everybody. And one of the ways that, in a very kind of silly sense, that I think about it is, my name is Jordan, right? And growing up through the 80s and 90s, that was not a common name for little girls. I found myself put on many little boys' basketball teams at the YMCA and things as a result of it. And my parents knew specifically that they wanted to do a gender neutral name when they named me. And I grew up for so many years with people being like, "Well, did your parents just want a boy and decide to name you Jordan anyway?" And I'm like, parents wouldn't do that, number one. But like it was this very interesting dynamic with my name. And I once had an email a couple years ago that was accidentally sent to me by two people who were kind of like research collaborators that were talking. And the email basically said, "Oh, I didn't realize Jordan is a girl." And I was just like, "Well, number one, I'm not a girl. I'm a full-grown woman." But number two, it's interesting that this person, had corresponded with me for so long via email on things, and we had never met in person. And of course, they had a perception of what my gender was specifically based on my name. And that was all prior to, having my pronouns in my email, right? And that has not ever happened since I did that, right? So as a person who's cis and has the privilege of that particular identity, even I have, had benefits from gender affirmation, right? The ability to say, "Hey, these are my pronouns," and in ways that, might have seemed kind of silly before, but it's a really kind of easy example on how very small interventions can really perhaps improve the quality of life for somebody like me, but in particular for trans and non-binary folks, for a whole host of mental health care related outcomes, a whole host of societal outcomes. We know based on evidence that gender affirming care has immense positive impacts on these patients, and for very kind of simple interventions that could be integrated within the healthcare system.
I can actually relate to you on that. So my name is Tony, and growing up, it was just constantly, especially from older generations, what is your name short for? Because most of the time Tony is either Anthony, or as a girl, it's usually Antonia, Tony. And so I relate to you on that, and I totally see your point on how gender affirming care for everyone literally benefits everyone. So, what are the potential consequences, though, for patients who are searching for gender affirming care and don't get that from their healthcare provider?
Well, similar to, as I mentioned, the kind of patchwork at the state level of services available for reproductive health care, we are seeing a very, very similar trend in those happening for the availability of gender affirming care. Number of states have enacted laws that have severely limited access to this particular type of care. And this has caused a lot of havoc, right? People who had been perhaps seeing clinics where those clinics have now had to close their doors. Parents in particular that are now faced with, do I take my child out of state in order to access the care that they need? Do we move our family to another state as a result of these laws? So again, we have encountered kind of a patchwork of places where patients who were previously accessing a form of healthcare no longer can do so and are faced with the decisions downstream from that. And, when you think about the consequences of removing that care and saying, okay, so, if this in particular minor is no longer able to access gender affirming care through this clinic, what are the consequences to that? The consequences are literally life and death, and that's a really important thing to understand here. Stigma that is experienced by trans and non-binary communities, in particular, when it's embedded in healthcare and the inability to access the healthcare that they need, has significant impacts on mental wellness and well-being. Number of studies have shown massive connections between depression and anxiety, and suicidality associated with not being able to access gender affirming care. So, not that, like it's more important for young people versus older people, but these in many cases are children, right? And I think that if anything can be a very unifying thing to think about, because I can't imagine that there's anybody, regardless of your beliefs, that would want to see harm come to young people, right? We really want to invest in children, both from like, personal and moral perspectives, but also from like a societal perspective, because, healthy kids grow up to be healthy, productive adults. Hopefully, that's our whole goal, right? So the idea here of removing this type of care, we know is associated with a host of negative health outcomes. And that's what makes this really scary, right? And that's what a lot of parents in particular are grappling with right now on how to be able to take care of their children, and to ensure that they do grow up to be adults and that they don't have so many barriers, put in the way of their care. So to me, it is a really scary time, trying to, again, protect the ability for patients to be able to work with their healthcare professional and be able to access all of the services that might be relevant to their care, without intrusion into that particular very, very special relationship.
I think what's maddening, and Tony's heard me say this every day and we've seen this in the testimony we've written in the counter arguments, is we have evidence that taking it away harms, and we have evidence that giving it helps, yet we still pass it. And, I say, we'd love science to be involved in policy or policy designed by science, and that's just not possible. So we have to go to anecdote. But now the anecdotes don't even work either, all those examples you've said. So it's, do we do more research? And I honestly think it's representation, right? There are several state lawmakers who are identify as trans, and but the thing I always think about is the story of the state legislator in Montana who was kicked out of the body, right? And forced to like work in the hallway. And so even there, the amount of the mountains that these folks have to climb for representation, I think we there's still a long ways to go. We've talked a lot about policymaker and keeping evidence-based treatment in patients in mind. What's your solution, or what do you teach in terms of how to, besides writing the editorial, like how do we let policymakers know, or how do we get things, is it editorials in newspapers or in the things that policymakers read? What do you think?
Well, and as you're talking about this particular issue and, saying, well, the science hasn't worked and sometimes these narratives aren't working as well, what it makes me think and reflect a bit about is when I teach about vaccines, for instance, one of the things that we talk about is, how to work with vaccine hesitancy and how to, engage patients in conversations ultimately with the goal of them either vaccinating their child or vaccinating themselves. And one of the things that we discuss in that is that most people are not making decisions based on a lack of information. I think that's a place that, as healthcare professionals, because we are such like objectively driven individuals. We kind of focus on the science. I as a researcher, I immediately think, what's the research to do to prove this to people, right? But like from our social science colleagues, they would tell you people are not making decisions based on a stack of evidence in front of them. Most of these decisions are emotional. And if you're ignoring the emotional aspect of decisions when perhaps working with something like vaccine hesitancy, you're unlikely to actually, make any difference here. So you have to think about that whole host of factors that go into an individual's decision to vaccinate. So I'm going to take that same sort of approach and apply it here. And the fact that, like, you're right, we have evidence to say that, like, or we have, I should say, experience saying that providing heaps of evidence to our legislatures is not necessarily working, right? Despite the fact that as scientists, as healthcare professionals, we understand what this communicates and we understand that things are pretty clear. So, the emotional aspects are really where I think we have to focus on. And, I think to your point, like the narratives of people talking about these things, if we're talking about storytelling, for instance, is a really effective mechanism that we can use in vaccine education. That's one of the strategies that's recommended of talking about, as a doctor in particular, like a pediatrician, trying to recommend vaccines to people, you might draw on the fact of, let me tell you stories about my other patients where things, have been really positive or where we've been able to avoid negative consequences. The same approach I think can be used in this arena of gender affirming care. I've seen over time, both at kind of local and state and also kind of federal levels, we've seen some really, really brave kids that have provided testimonies and have shared their stories at great risk to their own kind of, like mental well-being and being subject to sometimes the harm that can come to them after speaking in such a public way. But some really, really kind of brave and amazing people that I think know this concept. They understand, like, I want to show you, like who this law is impacting. I want to show you that I'm a kid, I'm just a kid down the street that plays with your kids. And all I want is the ability for a future. I want the ability to be able to work with my doctor to do the things that support my mental and physical health. Because that's really what this kind of comes down to. So these are the sort of levers I could say that our profession and all healthcare professions perhaps need to start pushing a little bit more, is perhaps moving away. I don't want to say moving away, but perhaps incorporating the importance of all the emotion in this alongside of all of the hard science that we've come heavily to rely on across our whole careers.
I think to kind of close us out here, I want to go back to your editorial, and you ended on a really powerful message that I wanted to share to the listeners. You said, our responsibility centers around the relief of suffering, advocacy to improve patient care, and the assurance of optimal health outcomes. Let actions reflect our principles for every patient. So with that note, I really just want to thank Jordan. Thank you so much for being here today, for having this great discussion. Reproductive healthcare especially is one of my personal interests, so I'm just happy to have this talk with you. Thank you for your expertise.
Hey, thanks for sharing the space today and giving us the opportunity to talk about some of these issues. My hope is that, people feel seen and know that, despite the fact that sometimes, days are difficult and we read about new changes that happen with laws that perhaps, feel scary, to know that, there are a lot of people that care about these particular issues. that are fighting every day in many different mechanisms in the classroom, in the legislatures, in research spaces to try and create spaces where everybody has the ability to achieve the health outcomes that they're looking for. So thanks so much for having me.
It was great chatting. And of course, one other space that you can find out about all of our content is social media, a bastion of only positivity and joy. So if you want positivity and joy, there's only one account to follow, and that is at PharmD That's Pharm as in pharmacist, at PHARMD as in doctor, Pub Health. We're on Instagram, LinkedIn, and all the other things that allegedly are social media related. So turn on post notifications, never miss an episode. Smash that subscribe button on our Spotify, Apple Podcasts, YouTube, Amazon Music, or wherever you listen to podcasts. Have a good day. Thanks.